very delighted to have Rajalingam, an old colleague at RP Center, who will now again talk about management options.
Management options.
As far as possible, try to avoid overlap so that we can have more discussion.
Thank you very much, sir. Thanks for AIOS and APOS for giving this opportunity. My topic is the DME management options. Slides. Excuse me. Excuse me, slides are not moving. Okay. Okay. So, because there is a lot of overlap in the topics, and just I avoid all this one.
You can highlight on the things which they have not.
These are the what are the management options available for the DME. So there are several treatment options for the DME management, and the choice of treatment depends on the availability of the retina specialist and infrastructure to deliver the treatment for the DME. So most treatment options are costly actually, and AIOS and VRSI, they have formulated their preferred practice pattern considering the different presentations of the DME in different clinical scenarios. So diverse approaches may be available depending on the location, type, and associated morbidities and complications. And there are some scenarios where the Dr. Chandramohan already mentioned that macular edema is divided into centrally involved and non-centrally involved, and the DME with other associated ocular problems, and the DME with systemic comorbidities. So before going for the management of the management options, we have to thoroughly examine the patient, take visual acuity using logmark chart, and fundus examination, that biomicroscopic fundus examination is very important, and color fundus photographs, especially the posterior pole, and if it's available, the wide field is very useful, and the fundus fluorescence angiogram, that is at baseline, to identify CNP, NVE or NVD. Then optical coherence tomography is very important tool, where you can classify whether it is a macular edema is central involved or non-central involved. If you have an option of having an OCTA, and to identify the macular ischemia is very important. And ocular examination and taking history is very important. You have to ask always the duration of the diabetes, then check the level of the hyperglycemia, whether the patient is suffering with hypertension or hyperlipidemia, and patient suffering with anemia or any renal problems. And at the same time, you have to take the history of the drug history, because some of the drugs can cause a macular edema, like prostaglandin drugs. So to differentiate between the CME and the diabetic macular edema. And at the same time, you have to take the history of any ocular surgeries, because cataract surgery with pseudophakia can have the same cystoid macular edema. So that we have to differentiate between the cystoid macular edema and the diabetic macular edema. So there are so many options available, steroids available, anti-VEGFs, lasers, and ultimately pars-plana vitrectomy. So steroids will act, chronic CME will act as an anti-inflammatory as well as anti-VEGF effect will be there. These are the different types of anti-VEGFs available. It is given all specifications mentioned here. And how this VEGFs act is by reducing the leakage and improve DME, and by promote rapid progression of the retinal neovascularization, and it improves NPDR, and it acts by reducing progression of the capillary closure and promotes reopening of the recently closed vessels, and it acts by causes regression of the iris neovascularization. This is the landmark studies is mentioned here, and the treatment landmark scopes where the FDA approval have come. The journey has started from the 1985 to up to here. And this is a logarithm which will give the management of the diabetic macular edema. But before the OCT comes, we have classified like a focal macular edema and diffuse macular edema.
Let's come to some examples, because algorithm to बहुत सारा हो गया है.
Sir.
Let's come to.
Sir, this is the chart showing that central macular involvement and non-central macular involvement. when the central macular involvement macular edema is there, you have to see the visual acuity, 6/9 or worse. You have to go for an anti-VEGFs. And at the same time, if the OCT says more than 300 micron, you have to always choose for the anti-VEGFs. And if you have if you find out any drill findings, you have to always give the poor visual prognosis even after the treatment. If the patient responds good, then you have to subject the patient for the PRN method. And if the patient gives poor response, then you have to think over whether you have to change the same drug in the same group, or you have to select the drug from the different group. So you have to give the injections monthly for 1 to 6 injections, and till the central macular thickness and visual acuity improves. And later on, you have to follow the patient every monthly for 3 months, and after that every 2 months for the 2 years. Then subject the patient for the PRN treatments. So this is a good response where 25% of the macular thicknesses or more reduces in after the 3 injections. Or if the visual acuity improves by ETDRA 5 letters or signals or 1 line. If the poor response is, if the macular thickness is reduces less than 10% or less than 1 line improvement in the visual acuity on the Snellen chart. So fixed treatment and PRN treatment, where the treatment only performs upon the disease recurrences in the PRN Gen1, but ultimately treat and extend is the best choice, where you can the patient can benefit in both ways. Then the patients who are non-responders to anti-VEGFs, what you have to do is, if the patient is taking the bevacizumab and not responding properly, then switch over to ranibizumab. Later on, if it's not responding, switch over to aflibercept. And many doctors prefer switch over to the
Rajalingam,
aflibercept.
there is so much confusion happening now, because Mallika says you start with aflibercept. You say you start with Avastin, then ranibizumab, then
Anyhow, time is up.
So do you follow this?
Yeah.
You follow this?
Usually, because we are working in the government sector, we usually for
Diabetic patient is same, na?
the
Government.
diabetic patient is same,
let it
but
be
we
there.
usually follow
follow
because she has a lot of experience.
We'll go on to the question answer. Actually, Lalit, can you prepare your presentation?
Let him
Get it
finish,
ready. No, it's over. No.
So when to switch over the steroids, responding to anti-VEGFs, but difficult to maintain frequent follow-up visits. Second one is pseudophakic patients who have reached a plateau, that is a persistent intraocular fluid, or less than visual acuity less than 6/12, or persistent edema and needing cataract surgery. So the other conditions are occurrence of systemic vascular event while on anti-VEGFs. The other conditions are associated features such as extensive hard exudates and presence of hyperreflective dots on OCT, and ultimately eyes of post-vitrectomy also you can use for this one. Where is the role of laser in DME? So additional laser may be considered after 4 to 6 injections of anti-VEGF for the following: persistent CME with visible microaneurysms. If a switch to spheroid is not possible, that is a glaucoma or a young phakic patient, then you can subject the patient for the grid or focal laser. So role of vitrectomy in DME, where DME with predominant vitreomacular traction is there, where DME with a tractional epiretinal membrane is there, when DME with a taut posterior halide, where you can go for the vitrectomy. Then PDR with DME. Treat naive PDR should be treated with panretinal photocoagulation. In presence of extramacular traction, PRP should be done 2 disc diameter away from the traction. DME treated as a per standard protocol. In the presence of the vision threatening traction, vitrectomy is indicated in addition to the PRP. So the presence of traction threatening or involving the macula is an indication for the surgery. Anti-VEGF should be avoided in case of traction, as it can lead to worsening of the traction or Crunch syndrome. Before giving anti-VEGF in PDR with vitreous hemorrhage, B-scan should be done to rule out any traction involving the macula. Then non-resolving vitreous hemorrhage always requires a surgery. So PDR with DME in presence of the traction, a vitrectomy is indicated. In absence of traction, PRP should be done to the extent and area possible. Anti-VEGF can be used to treat DME. It may prevent rebleeding from the neovascularization elsewhere in the eye. So DME in pseudophakia. So differentiate DME from the pseudophakia. So you have to identify the microaneurysms or hard exit that shows as a diabetic retinopathy, or if you done FFA and you find a flower petal appearance, that is shows it's a CME. So we have to differentiate between the DME and the diabetic macular edema. In presence of both DME and the CME, topical NSAID drop should be used followed by anti-VEGFs. In non-responders, switch over the steroids. DME with pregnancy. Anti-VEGFs in pregnancy is not recommended because of potential effect on the developing embryos or fetus. Wait at least 3 months after the last intravitreal injection before conceiving. Dexamethasone implant is recommended. Spontaneous regression DME is reported after delivery. So DME with type 1 diabetes. Among all diabetics, 27% of individuals with type 1 diabetes and almost all develop diabetic retinopathy within 9 years of onset. Puberty is a well-known risk factor.
Dr.
for the diabetic
Rajalingam, I
retinopathy.
request you to kindly conclude because we are very short on time now and we only have 3 speakers. You can go to your conclusion, I think.
Okay, we'll. So there are few. So in conclusion, DME is preventable to some extent. There is a need to optimize the control of systemic factors, including hyperglycemia, hyperlipidemia, and hypertension. Care should be done holistically by multidisciplinary team with a physician, endocrinologist, internal medicine specialist, or primary care physician being the center of the patient care. Significant improvement in the management of DME can be achieved by choosing appropriate drug. Though anti-VEGF are the first line of management, coexisting ocular disease and associated comorbidities may alter the management strategies. Thank you, sir.
Okay, thank you, Rajalingam.